This conference will now be recorded.
Hi, welcome everyone to the ACRM Spinal Cord Injury web series. My name is Swati Mehta and I'll be moderating the presentation today. I'm part of the Secondary Conditions in Aging Task Force chaired by Jean Banka. And Jean, I just want you to come say hi.
Hello everyone and thank you for joining.
Thanks, Jean. So our goal is primarily to promote healthy aging amongst people with spinal cord injury and also to assist with prevention and management of secondary complications. If you'd like to join our task force or learn more about what we do, please feel free to contact Jean or myself. Now, before we start the presentation, I'd like to take get some housekeeping out of the way. I'm going to ask everyone to mute their devices during the presentation so that we can minimize any background noises that might come up. And then during the presentation, Jean and I are going to be monitoring the chat. If you have any concerns, please let us know. And then we've also allocated lots of time at the end of the presentation for discussion and questions. So at that time, if you could use either your chat feature for your questions, or you can unmute yourself and ask the presenters your question, that would be great. Now, the overall aim of the webinar is to give us a brief overview of knowledge implementation process and to see how we can integrate that into clinical practice and research. And we're really excited to have two knowledge implementation specialists joining us to speak to us about their experience in implementation of a pressure injury prevention best practice guideline across all the Canadian spinal cord injury rehabilitation sites. Dr. Carol Scovil is an implementation and evaluation specialist at the Brain and Spinal Cord Injury Rehabilitation Program at Toronto Rehabilitation Institute. Dr. Dalton Wolfe is a scientist at Parkwood Institute St. Joe's Healthcare London and the leader of the Research to Practice team at Parkwood, which integrates clinical and research efforts to improve care and clinical outcomes. Now I'm going to hand off the presentation to Dalton, and he's going to get us going. Thank you, Dalton.
Swati, there was someone's note who came up saying they couldn't hear.
Yep. Elizabeth, I see that you can't hear. Is there anyone else that cannot hear?
Sorry, I was on mute. Apologies for that. But I think there was people that couldn't hear you as well, Swati. So we'll just double check if anybody is continuing to have that problem. But in the meantime, we'll just continue on, I think. And we're really excited, both Carol and myself, to be able to give this presentation today. It is based on a paper that was published in Archives of Physical Medicine and Rehabilitation. And should be able to see on the screen from the front page all the authors, etc. And really what this represents is the work over quite a long, like a 3 to 4 year period of a network in Canada that we call the Spinal Cord Injury Knowledge Mobilization Network. And both Carol and myself have really are involved in a new network that has taken this work and applied it to another network so the SCI KMN for short, is no longer in existence, but it has evolved into a new network that works out of Ontario called the Implementation and Evaluation Consortium. And I think you've already introduced this, Swati. But really, today we hope that you will get a great idea of not only what we have done and the processes that we followed in the KMN and how we attacked the issue of implementing, but also what we achieved. And then we are trying to leave a fair bit of time to discuss what the implications of that. So while the topic area might be our implementation practices around sort of pressure ulcer practice or pressure injury practice, we really hope that these are broad implementation strategies that can be applied to multiple contexts. And so in particular, we will talk about incorporating different knowledge implementation strategies, both in clinical practice and research, and we'll use what are called the active implementation frameworks, which I'll speak a little bit more about, so that hopefully you have an understanding of what that exactly means. And then we'll also talk about some of the barriers and facilitators of success or lack of success associated with our implementation effort. First, a little bit, the title is a little bit misleading. So our network, the Spinal Cord Injury Knowledge Mobilization Network, which we may refer to in the presentation as just the KMN, actually involves 7 centers. And so represented here are the 7 centers. Toronto, 2 sites in the province of Quebec, Montreal and Quebec City, and then London and Edmonton and Calgary in Alberta. And then coming after we had already got started, a site in Fredericton, New Brunswick joined us. And so they weren't represented in the data in this paper, but then came in partway through, and we went on to work in the implementation area of pain and how to enhance pain practices in spinal cord injury rehab, and so they were involved in that work. So just I'm going to go through a really brief, and Carol, you certainly can chime in at any moment if you would like to make sure that we get to your most exciting part of the presentation. But really just a bottom line or an introduction to what we mean by implementation science. And we borrow heavily from an implementation research network called NERN, or the National Implementation Research Network. You can see the reference at the bottom of the screen, bottom right. So there is a website that if you're interested in learning more about NERN, you can find out lots of information and resources about what they do. But essentially they define implementation as some key points really being about purposeful activity. So well thought out, well planned, and that you're really putting in place at a practice, program, or intervention. And the idea is that you know the dimensions of what you're trying to put in place. So often, maybe the practice or the program is sort of thought to be, as in the case of best practice guidelines, thought to be known, but when you really dive deep, you maybe don't know all the aspects of it. So in a carefully planned process, it's important to really dive deep into what the practice is that you're actually trying to implement. And we all know, I think, much literature on the issues, and we've all probably had personal experience where we had great intentions of implementing something in practice, and we've seen the literature, I think, that it takes a long time to implement something, and not necessarily is all that we intended to implement actually sustained in practice. Sometimes none of it is sustained. And the other key point I think that this is making is that we often focus in healthcare on the intervention itself, and all our research background is really focused on, is an intervention effective or not effective? Or is it efficacious or is it not efficacious? Whereas in actuality, it could be the most effective intervention possible, but if we actually don't implement it effectively as well, we won't actually see the actual benefits. So you need both an effective intervention and an effective implementation to really see the benefits of something. Just a little bit, so there are many, many different forms of implementation practice. The one that as I had mentioned, that we had adopted is associated with the National Implementation Research Network. They are based out of the University of North Carolina, and they use a term called active implementation frameworks. And really, there are 4, and now actually recently they've added a 5th framework, and it really comes down to based on some cross-sector analysis that they've done. It's sort of 5, and I'll talk about 4 here. 4 essential frameworks are that you have a dedicated mandated team, that implementation unfold in a planned sequential rollout from exploration to installation to initial implementation and finally to full implementation. And that process does take time and effort. In fact, there's some literature on really doing a full implementation may take 2 to 4 years. Often we try to do things in the order of weeks and months. Another key concept is that there are key implementation drivers, or in other words, structured infrastructure or ways that you might put in place something. I'll talk a little bit more about what implementation drivers are. And then I think most of us have heard about improvement cycles. The most common one of these is called the PDSA, or Plan, Do, Study, Act, but essentially really saying that in order to implement effectively, you tackle part of an overall implementation and you follow a process to really determine, is this having an effect? And that feeds into another planning cycle, and constant evaluation is really the way to make things happen. So just a little bit on implementation stages, and really the idea here is that each stage of implementation has some core activities or processes that one must follow. We aren't going to dive in really deep into what those processes are today with the time frame we have, but both Carol and I would be willing and happy if anybody wants to sort of dive more deeply into what these processes might look like. Happy to have follow-up on that. Essentially, in the exploration stage, the idea is really drilling down into what clearly will be adopted and implemented. The installation stage is then really getting into the how that's going to happen, and what needs to be in place before you actually start the implementation. So it might be an information system that needs to be in place before you start the implementation of the actual practice. Then it's really getting down to who actually is going to be involved in the implementation and making sure that everybody is trained, ready to go, and the word here is activated, to put things on the ground and implemented. And then within the full implementation stage, it's really about trying to improve and using PDSA cycles to gradually move into the case where the practice is business as usual. I mentioned that implementation drivers are a core key aspect, and really the words around the outside of this diagram reflect what we call the implementation drivers. And you can see that there's 3 along the left side dealing with staff competence. Usually in healthcare, people do these things intuitively and say, oh, if we're going to implement this, we need to train. And less frequently, but probably more importantly, they may start to think about how they might develop a coaching strategy. But really, if you don't have some of these other drivers in place, and again, we can follow up with a little bit more of what these things actually entail, but if you don't have things like performance assessment, determining if the practice is actually happening in place, or potentially decision support systems, or leadership buy-in from what is either technical or adaptive styles of leadership, or potentially it's just having an environment that is facilitative to all aspects of the implementation. And it may be something as simple as, making sure forms and things are readily available in the place where the implementation is actually occurring. Really the key things, this is a really key activity in implementation, and so we wanted to highlight this, that before you actually start implementing, you really need to look in your environment and see what things are already in place in these certain areas, and that's a core process that we found really helpful in our implementation efforts. And then finally, the last framework, the improvement cycles. We won't spend much time on this, but I think many of us know about it in healthcare. But the idea being that there is a plan, do, study, act process that we can all follow. And the idea is an effective implementation. Typically, you run many, many of these in very short iterative cycles to put a more complex practice in place. And lastly, I just want to talk briefly with our experience in the KMN. We really found that 5 key activities. Implementation scientists are famous for making something seem really complicated. We had several consultants come and work with us over the life of the KMN, and really it came down to, I think, these 5 core activities and the processes associated with them. So forming an implementation team and making sure that leadership and all concerned understood that it was mandated, a dedicated team, adequate resource with adequate expectations. A process of understanding the practice. There are tools called practice profiling tools, and using those tools to really, again, really understand the practice before you attempt to implement it. It may be that it's not just a single practice. When you actually look at it, there might be 10 or 15 subcomponents of the practice, and you really need to understand each element or each piece of that. And finally, moving down to identifying what needs to be in place in your infrastructure using that driver's analysis that I talked about, and you use that to create an effective implementation action plan. And finally, putting that plan in place is really where the fun begins, and using improvement cycles to strive for constant improvement. So with that said, I know I ran through a lot of content there, and now I'm going to turn things over, though, to Carol, because this is where the action really begins. And with that implementation introduction, hopefully Carol can talk a little bit about what we did and some of the implications of that work.
Great. And Dalton, you will advance the slides for me, will you? Please. So yeah, we were, as Dalton said, 6 sites across Canada initially, and we needed to, we had been tasked with thinking about improving practices in pressure injury prevention across all the sites. But we weren't given a lot of, we were given a lot of freedom to choose what those practices were. And so we used a modified Delphi process to select those processes. So we had 3 existing pressure and injury best practice guidelines, and we identified 45 different best practices that we could potentially implement. And together in this Delphi decision-making process, which we included clinicians, people with lived experience with spinal cord injury, researchers, hospital administration, and then the funders, we came together with all our perspectives to try and select something that we could agree was had good evidence, was important and was needed to be done, but also was feasible and sustainable, something that we felt we could do across 6 different, very different rehabilitation hospital sites, and then potentially could be scaled to other sites. So that was the decision-making criteria, and then we chose 2 practices. So one was the completion of a comprehensive pressure injury risk assessment and prevention plan. So this was widely recommended in all of the best practices, but then we said, well, like, what is this actually going to look like? And so digging down into that a bit more, we said that at each site we would use a structured risk assessment instrument to see at admission what patient's individual or pressure injury risk was, and that sites could use either the Braden, a commonly used pressure injury risk assessment, or the SCIPUS, which stands for Spinal Cord Injury Pressure Ulcer Scale. So sites could choose what would work best in their context. We wanted to give that kind of flexibility. And then the best practice guidelines also recognize that we need to have not only a general risk assessment, but then an individualized risk assessment by an interprofessional team and a prevention plan that comes out of that is based on individualized patient need. So that's breaking down already into some of the pieces what a comprehensive risk risk assessment would look like. We also wanted to make sure that we were providing excellent pressure injury prevention education to the patients in our hospitals. And we wanted to make sure it was offered in multi-modes, that people had various opportunities to learn about pressure injury prevention. And this included structured group education sessions, which happened at each of our hospitals. Education materials, so either printed handouts or online resources or both. And then also we recognize that one of the most important ways of teaching is the unstructured, individualized education that's happening one-on-one by the nurses or the therapists at the bedside or in therapy. We wanted to make sure that that was there as well. And we have an empty slide. There we are. So in terms of outcome, yeah, we missed one. Can you go up, Dalton? Interesting. So I attempt to share my screen because that's not got, I don't know if others can see anything on that slide, but I cannot.
In our test, that looked fine before. I'm not sure what happened there, Carol.
Of course. Let me just see here. I'll make this big and then I'll share it. Now, can folks see the results on this screen now?
Looks great.
Okay, good. So the first thing we wanted to look at was that standardized risk assessment. Now, this was something that was required at all 6 sites across. This isn't like, this isn't new, but this was something that was required at all our sites. And as you can see, pre-implementation, so what was happening before we came in, we first wanted to know what's the state of things at our sites. And we found that it was actually being done pretty inconsistently, less than half the time, despite it being a required standard in all of our hospitals. So this was something we definitely needed to address. And as you can see with the overall results, we had well over 90% sustained over 3 or 4 years. So we really had an excellent uptake in improving this practice. Now, this was a case where we really wanted to look at what was best for each site. So it ended up being that 3 of the sites chose to continue with the braid-in. It was familiar with their nurses who were doing this initial assessment. And it was the same assessment that would be done across the hospital for other populations. And they felt like it made the most sense to keep that consistent. That was going to result in the best outcome in terms of allowing people to implement the practice that we wanted to do. The other sites, it was really felt important that not all the staff felt that the braid-in had something that was completely relevant to the spinal cord population, and there was a lot of buy-in when we said, let's do a spinal cord specific pressure injury risk assessment. And so at 3 sites, it was chosen to switch to a spinal cord specific one. Now, one of the things that you can see on here is that we have late and on time, which is primarily the most of them, but then some late. The reason was we wanted them done, ideally, within 24 hours of admission. But the reality of busy hospital session is that doesn't always happen. And so we wanted to, you have to allow in implementation some space for the reality of what's happening in the system. In terms of implementing the risk assessment scales, this was one where obviously we did a lot of training, and training not only in how to complete the scale, which most nurses had the background to know anyways. We maybe did some refreshers, but that was not too much of a challenge. What we really found we needed to spend time on training was the processes. How do we make sure you know where the form is found, you know where to put it when it's done. In terms of the SCIPUS, we had to deal with getting some blood work results to look at that scale. So what are the processes involved in there? And we really found that coaching so having people on the units who were champions, who someone could go to if they had a question about how to do the scale or what the scale questions were, and could check in with people if they were having problems. The other thing that was really helpful in this, in terms of implementing, was making sure we did regular, really early evaluation, so those PDSA evaluation cycles, and seeing where things were falling through the cracks and trying to address them. So in addition to that structured risk assessment, we also, can I make it go to the next slide? There we are. We also had, we had this individualized prevention plan. This one was a real challenge to implement. So the way we structured it at each site was slightly different, but essentially we needed to have some way of not only doing it, but having a way of recording that it had happened. And that, I think, is where our major challenge came down. We all felt quite confident that these discussions were happening amongst our interprofessional teams. However, getting everyone to sign off on a sheet and write those plans down, or go into the electronic record and sign off there, was a real challenge. This was something that we really brainstormed a lot together with our teams at the different hospitals. We all had different challenges. And again, we wanted it done within the first 10 days of admission. That even was challenging based on when rounds happened, and again, getting people to fill in that form in time. So this was one where we actually felt on the ground like the implementation of what does each profession have to offer in terms of pressure injury prevention, and what kind of plans are they each making. This was something we all felt was an important discussion that increased due to the implementation. However, that data collection for, like, how are we proving it? How are we able to say that we did this? Was a real challenge, and we never really, in the end, came on a good way of fully evaluating this. So this was one that really goes to show that the structure, certainly some of the sites didn't have an electronic record, whether that would have helped improve the results, it's hard to say, but this was one that was challenging. Looking at education and the different types, the class-based, the materials, and the individualized, you can see an increase across the board. It was already going on in a reasonable way at all the sites. Not everyone is going to want to go to a class, but we were happy to see that almost everyone was receiving individualized education. And this is one where I think because it was already happening, that initial implementation didn't show a big change right away. So we all improved our education handouts. Some people restructured their classes. We did a lot of work with all the individual professions so that they were recording those one-on-one bedside or therapy sessions where you're having those individualized conversations. And that one didn't happen right away. And that was where the PDSA cycles and really giving feedback and coaching really helped to change the results. So we were implementing all of these practices in order to improve our pressure injury practices, ideally with reducing the incidence of pressure injury. So just to orient you to this grid here, we're reporting a number of different numbers. So admission is the number or the percentage of patients who arrived at a rehabilitation site with pressure injuries of different stage levels, and then a summary at the bottom. The incidence is the one that we were most interested in. That is the percentage of patients who developed a new pressure injury while they were with us at our rehabilitation center. And then prevalence is just not quite the sum of those, because people could fall in both categories, but prevalence is looking at the total number of pressure injuries. So some of these numbers seem big. However, these are pretty in line with what we see in the literature. People with spinal cord injury are at high risk for pressure injuries. So, I mean, the number that we tended to go with was that the number that developed a stage 2 or greater was 7%. And that number did not change significantly between pre-implementation and post-implementation. So we did all these things to improve our education, our staff education, patient education, and also risk assessments, and we didn't see a big change. So that was a bit surprising, and I'll talk about that a little now. So first of all, we felt reasonably good about the best practices that were implemented, although we really did find challenges with documentation of interdisciplinary assessments or analysis and prevention plan. Why didn't we see a change? It's hard to say. One is that while looking at patient risk and creating prevention plans and doing patient education is all universally recommended, there haven't actually been randomized trials. This is all done as expert advice in all of the best practice guidelines. And so it may not be that it's directly connected to reducing pressure injuries in rehabilitation. We would hope that it might actually have a reduction as individuals with spinal cord injury move into the community because they have had better education while they were here. Certainly we had good feedback as people were approaching discharge, that they could teach back some of the information they had learned and were able to be more proactive, but we weren't measuring incidents in the community. We were measuring incidents in our rehabilitation center as people are recovering their function. And so perhaps these practices didn't change during rehabilitation. The other thing that might have happened is that we were looking a lot more carefully. We were doing skin checks more thoroughly. We were documenting pressure injuries more thoroughly. And so it may be that we saw an increase because there was or we didn't see a decrease because any decrease was masked by an increase in reporting. We can't say, but that was where we ended with that. But really, we all felt like this was an incredibly helpful process to be involved with at all of our sites. We felt like for all of our sites, it really improved our pressure injury practices. In addition, we looked at continued refinement of some of these risk assessment tools for within spinal cord rehabilitation. So the Toronto and Montreal site worked together to really look at the psychometric properties of the Braden and the Skypus scale, as well as comparing them to some of the prediction you might see, looking at FIM risk, for example. And some of those, they are in the process of coming up with potentially a new scale that would work even better within the rehabilitation site, because the Skypus was created in community dwelling. And so maybe we need one that is very specific to rehabilitation. We all felt we had an increase in local implementation capacity, meaning we all learned a lot about how to implement practices well, and that this carried over into a lot of other initiatives that were happening at our sites. It was really helpful to have that community of practice that we were working with and brainstorming and learning from each other. And as Dalton said, these learnings are now being used in a provincial spinal cord consortium in Ontario. So really that participating in a network, sharing learnings, I've already mentioned. Another really key facilitator is when we were part of a spinal cord injury network, we could really look at our, we could go to our administration in the face of all the improvement things that are going on at every hospital all the time, and say, this is one that we have funding for, and we are responsible for, and we have this community we're doing it with. And it could really keep some of those key spinal cord practices front and center, even as there was delirium training and other things going on. And then really trying to make sure that as you're implementing practices, that they have meaning at your local site, and then comparing how that changes across sites was helpful. It was absolutely essential to make sure that we were engaging everyone as we did this. So the individuals with spinal cord injury, the frontline clinicians who are actually doing some of these tasks, that we had research support and decision maker support, and then funders were able to be involved in helping shape the practices that were implemented. And really building capacity for best practice implementation was so valuable, and we all found that we applied it to our local priorities. So looking at those key facilitators, looking at the drivers to tailor implementation to your local context. We all found it a really helpful learning to not only train, but really be coaching and following and supporting staff for quite a long time so that you're enhancing sustainability. Do those evaluations really early. Do your PDSA cycles quickly. Don't assume that you've implemented something and it'll be okay. Implement something and test it within a week or two, and catch some of the issues and do another, tweak things and do some more implementation. One thing that's really important is look at what you're already doing well in your site. What people do you have that you can call on? How can we tweak or add to existing processes rather than creating something new? And if you have to create something new, then really it's important to spend time thinking about what you can stop doing to create some capacity within your system, within your staff, to look at implementing these new things. And really, details and process matter. They're often what stop the practices from being implemented and sustained, right? People often, as healthcare workers, understand the processes, but can they do them in the reality of their busy jobs? And are the supports in place to enable them to do that? It's that details and process that can really make or break whether things are implemented sustainably or not. I think that brings us to the open discussion, unless you have anything to add, Dalton?
No, I think we should just get into questions, and thank you very much, Carol.
Perfect. Thank you, Dalton and Carol, for that informative talk. I really appreciated just kind of starting off talking a little bit about the implementation process and breaking down the stages before learning about the results. I felt that that was really helpful for me because, as you mentioned, implementation can be very complicated. So that really helped break things down for me. Now we're at the point where I welcome any questions you guys may have. You can either text it to us or you can unmute yourself and ask questions.
Hi, it's Elizabeth. I'm from Quebec. I'm working with Health Standard Organization and Praxis on an SCI Inform project, and thank you very much. That was a wonderful presentation, very impressive work on so many sites. My question is, and I don't know if that was part of the scope of your research, and if so, I'm sorry, but I don't think that looking at how for the people with the experience of SCI, did you had any data or information on how much this education helped them furtherly prevent having pressure sores when they transition back home and are discharged from the hospital? I don't know if you looked at this, but if you only had some informal discussion with the patients or providers on this, it would be I would be interested to hear about it.
Do you want to take that, Carol, or would you like me to?
Sure. I mean, we did not evaluate it. It was not part of the scope of what we did to be evaluating pressure injury prevalence incidents in the community. So really it was a sense of how much were people able to articulate what they had learned about it while they were with us. Now, the one exception was Edmonton created a really significant pressure injury education system, and I believe they tracked a number of patients, asked how much they had, what they had learned was sustained and whether it was useful, and they got some really helpful information there and generally positive. But again, that wasn't looking at pressure injuries. It was really looking at that education was it sustained in the community.
And I'll maybe just add that one of the most significant learnings is that we really need to do a better job on that when we scope out these initiatives. So the consortium that we've talked about that is now sort of the evolution of the KMN in Ontario is tackling that precise issue and looking at 6 different indicators, one of which we haven't actually started on tissue integrity, we're calling it, with that consortium. It's just fairly new, but we are following people for 18 months, and we'll get some ideas about how those things change within 5 participating Ontario sites.
That's wonderful. Thank you so much. And please, I'll definitely stay tuned for those further data and knowledge you have on those long-term follow-up. Thank you.
Hi, this is Jean Zenka, and I had a question about, I guess, the evaluation of things as well. I'm wondering, were part of the data collected at all about behaviors and skills? So knowledge is one piece, so we provide education, and then a patient may know that they have to do a particular thing. Was there any data collected about whether or not they actually did that thing, like a pressure relief, or the frequency of that, or the appropriateness of that? That may fall beyond the scope, but I'm just thinking about all the things down the line that we assume will happen if we do the first thing, but may not.
Absolutely.
Go ahead, Carol. You go.
Yeah, absolutely. And again, that was not something that we formally evaluated, but I know was focused on at a number of the sites. So not only do you have the information, but are you using it? But again, it wasn't evaluated in a. Part of the reason is to evaluate something across 6 sites, you have to have a really clear and consistent thing that you can evaluate, as it was, because of the difference in sites and the difference of the way people approached it. Then we didn't have a clear outcome to measure. We could have done an interview where we, I don't know, had done something where we had people demonstrate, but we didn't have an evaluation of that, so we can't easily say, although I think at each site we observed that happening. Dalton?
Yeah, and I was just going to, that's exactly the case. I know within our own site, we did do sort of 2 or 3 different snapshots in time of, 10 to 20 people and got down to the behavior level. I will say as well that we did have patient-reported outcomes at the outset that were going towards that direction, Jean. So like I believe that I have the skills and knowledge too, or I can't remember the precise wording, and then there was also a self-efficacy question around confidence. So again, going down that path, everybody recognized that was an important thing, but was done more on an individual site level.
Yeah, and there's no question this is just a monster to wrap one's hands around in terms of the different layers. And then I do have another question, but I can wait to see if others have one they want to ask first.
Certainly.
Okay, so I'll go ahead fast then. So I'm wondering, here we talked about a lot of interventions that are part of the meat and potatoes of everyday rehab that we do. But of course, a number of researchers are trying to develop newer interventions or new intervention programs, or making new technologies, things of that nature. What advice would you offer to people who are developing interventions to think about at the research stage, when you're still trying to see if something's efficacious, to build something that's likely to transition well into also being implementable?
Well, will probably say the same thing again, Carol, so you go for it, especially with your engineering background, I think.
You're the one currently working in research. We're both trying to pass it off. Yeah, I think it's really about as much as possible as you're developing your technique, your procedure, your device, that you're thinking not only about how it works, like what the functionality of it, or what you're actually trying to get at with that, but also what someone will have to do to make it happen in the clinical setting.
Yeah.
And I know that's hard when you're prototyping things, but I do think it has to be considered early, because no matter how amazing something is, if it's very complicated or very expensive, it's probably not going to happen, even if it's very efficacious.
And I'll just add in, the end user design is essential. And end user design in most cases means thinking broadly about that, so that early in development involving not just patients, because we, especially in Canada, we have essentially our funding agencies are really advocating for consumer or patient involvement, but clinician involvement, administrator involvement, right up front, so that the designers can get an indication of, you know, from the ground, a sense of how this thing may or may not work.
Carol, hi, it's Sheila Casemore. Can you hear me?
I can, yes.
Yeah, good. So one question I have for you is, if you could change something about the whole project, what would that be?
Oh, that's such a good question. Dalton, do you have anything?
Well, I actually do think the baseline and the lead-in time, we were so much directed, and or all of us wanting to move into the implementation realm so quickly, that a little bit of a baseline period with a focus on measurement, so that we could make better, you know, before and after statements along the lines, and a little bit more thought into that evaluation side of things from the context of what might change. So actually, your question, Jean, on the skills, that would be a natural upon reflection that I think really could have had some attention to. And I know every site did their own thing, but not within a central perspective. So I would change the baseline. Mind you, you only have so much time within funding projects. So that was a bit of the challenge of that.
Yeah, and I think that the other thing that I might say is that something we've sort of already talked about is that really the initiative for this came from the community, saying this is a really big issue for us. And obviously, reducing it in the rehabilitation period is important to that, and providing education in that period is really important. But that's only a very small amount of time and a small period. So if, like in retrospect, and we're still figuring out with this new consortium how that's going to look. But I think if we had a way of better evaluating, better looking at those, implementing things into the community, I think that's going to have the largest effect. And we just didn't have the capacity to do and evaluate doing that, unfortunately.
Hi, it's Louise Clément. I work with Elisabeth at Health Standards Organization and working with practice. And thank you very much for this presentation. I'm not surprised by your results relating to individualized patient need plans, what we call in Quebec interdisciplinary individualized patient plans. And that's a real struggle. And I think one of the reasons is the why we do them. And for me, those should be those plans that enable self-management, with patients, and how those plans are what we give to patients to be, partners in their care. So I wanted to know a bit if you had any thoughts regarding, it's a very difficult way because we're no longer being provider specific, but actually comprehensive to patients' needs. So I wondered if you had any comments about that.
Very much so, because in our own research program, we've really centered on that, partly because of the experiences here. So in fact, there are several initiatives that are sort of spin-offs that really reflect on the way we might better embed self-management within the things that we do. And so we tend really adopting a behavioral approach, and to think about how things like goal setting, problem solving, action planning, which are some of the standard skills of self-management, and how those might be I hate to use the word taught, but facilitated during the rehab process in an intentional way, so that both the provider and the patient are understanding that this is a skill that can be applied to other issues as they emerge. It's a big area and it's challenging, but I really think it's a priority.
Yeah, and similarly at our site, since the beginning of this project, we have revamped our goal setting to be really much more looking at all the areas of spinal cord injury, and providing the patient a chance to express their goals, but also for the clinicians to say, and these are going to be some of our goals, and we're going to have to work together to make sure yours stay in focus and that we get some of these things done which are required for discharge. And so having some of those conversations and then following those through right to the end, looking at, as you go with the different, we call them domains of spinal cord injury. So yeah, it's an ongoing learning process.
Any other questions?
I have one more if I could, Swati. So as someone who is a novice at implementation science, what resources might you recommend for those of us who are more on the intervention development side to help us become more familiar with these concepts and think about integrating them into what we do?
Excellent. So in fact, I've been doing a little bit of consulting about that very issue. I really do think that pairing with, and there are so many schools of thought of implementation first and foremost, and there's a lot of similarity between them in terms, they just use different words, language, systems, but in the end, there's a lot of similarity. So I would urge linking up with sort of a facilitator to learn by doing while you're trying to put something in place, and have that consultant or expert be a true consultant or expert with the goal to minimizing the way that they work with you in an ongoing fashion, so that their focus is on skill development in that area for you to get your brain around, and passing tools and skills on to you, not doing things for you. Because and I think we saw quite early on, we had a few different consultants, and the ones that did that best ended up, helping us quite a great deal.
Mm-hmm. In terms of if you're in the position of not doing the implementation yourself, but wanting to think about it in the future, that's challenging. I do know that there's a number of knowledge translation resources out there that are meant for developers and researchers. Certainly one of the things we did as the KMN was created an implementation guide based on what we had received from NERN, the National Implementation Network, but really customizing it for our experience and for healthcare they work in healthcare, but their tools, they also work in education and in government and various places. So their tools are very general. So we tried to make them a little more specific and gave some specific examples. So that's a tool that's available. Yeah, I'm not sure in terms of thinking about it ahead of time. I don't know that you can do better than also just spend some time with the variety of end users, right? So the patient or consumer, but also the frontline clinicians and sort of hospital administrators who will be helping make whatever that is happen eventually, you'd hope.
That makes sense. Thank you very much.
Great. I just want to thank the speakers again. It's now getting to the end of the webinar. Please interrupt me if you guys have any other questions. But I just want to thank the speakers and just appreciate their sharing of their knowledge and their expertise with us, and really just inspiring us to kind of incorporate some of these implementation strategies in our own research and clinical practice. I also want to thank our audience for their participation and their engaging questions, and I really appreciate them being on board. And I just want to let everyone know that the recording from today's talk will be available within 48 hours on the website for ACRM. And I also just want to let everyone know that we're always looking for people to help join the community, and just kind of if there's any questions or if you're interested in joining, there's ways that you can contact us. You can either contact Jean and myself, or you can go to the ACRM website and contact Catherine Vandervarker, who's our membership officer. And thanks again for joining us, and I'll just be ending our recording, and thank you again, everyone.
Thank you, Swati and Jean.
Thank you.